epidermolysis bullosa acquisita. The epidermolysis bullosa acquisita we will talk about in brief. It is late onset, more than 40 years, increased HLA-DR2, trauma-induced or ultraviolet-induced usually, and may associate malignancy, lymphoma, myeloma, amyloidosis, inflammatory bowel disease, diabetes. Clinically, it either simulate epidermolysis bullosa dystrophica or porphyria cutanea tarda. There is tense pruritic, usually non-inflammatory bullae with which is usually pruritic and healed with scarring and secondary milia. Usually it is at the site of trauma or sun exposed, especially the extensor surface, as back of the elbow, knee, and also there is usually scarring, alopecia, and nail dystrophy. Sometimes it is bullous pemphigoid-like, sometimes it is widespread, tense bullae, and inflammatory. So clinically, there is tense pruritic, usually non-inflammatory, but it could be inflammatory bullae that heal with scarring and secondary milia, usually at the site of trauma or sun exposed, and scarring, alopecia, nail dystrophy, and sometimes rarely there is mucous membrane affection. This is, as we can see, the picture. Blistering, erosion, scarring, and milia at the trauma prone areas. And we can see here also another picture with a classical presentation with scarring and milia over trauma prone areas of the skin. And here we can see another picture which is bullous pemphigoid-like presentation with a widespread inflammatory vesiculobullous dermatosis. Could also be like cicatricial pemphigoid-like, and it could be also this presentation with peripemphigoid-like presentation, scarring lesions on the head and neck. Here another picture, bullae crusts and scarring at the site of trauma. And here also you can see two types of presentation: the classical mechanobullous presentation with erosion, scarring, and milia, and more inflammatory bullous pemphigoid-like on the trunk. This is the clinical picture. We will see after that the histopathology. Histopathology is subepidermal bulla with neutrophils. The direct immunofluorescence, there is immunoglobulin G and complement 3 deposition at basement membrane zone at the sublamina densa. Indirect immunofluorescence, immunoglobulin G against collagen 7 in sublamina densa, in anchoring fibrils in sublamina densa. And immunoelectron microscopy, it is deposited in sublamina densa. Salt split test, immunoglobulin G antibody bound to floor of the bullae, the dermal aspect. So there is histopathology, subepidermal bullae with neutrophils, direct immunofluorescence, immunoglobulin G in complement 3 is basement membrane zone, indirect circulating immunoglobulin G antibodies against collagen 7 in sublamina densa. It is in the floor of the bulla. Now we will see also the clinical, the histopathological picture, and also the immunoglobulin G deposition in dermoepidermal junction. Another also picture of direct immunofluorescence with staining immunoglobulin G deposits in perilesional skin of epidermolysis bullosa acquisita, the dense deposits within the dermoepidermal junction. we will talk about the pathogenesis. The antigen is epidermolysis acquisita antigen is type 7, called collagen 7 in occurring fibrils. There is recognition of type 7 antigen as foreign. Autoantibody formation, immunoglobulin G, bind to dermo-epidermal junction, and this leads to complement fixation, release of neutrophils and eosinophils. Proteolytic enzymes lead to separation at the level of sublamina densa. The treatment is steroid dapsone, azathioprine, immunosuppressives, and avoid trauma and predisposing factor and look for associations. Steroid, low dose 40 mg per day prednisolone, dapsone, azathioprine, immunosuppressives, and cyclosporin, intravenous immunoglobulins, and plasmapheresis with avoiding of trauma and predisposing factor association. Bullous systemic lupus, it's almost the same, but clinically it is either bullous pemphigoid or DH-like, but not pruritic, and also there is criteria of systemic lupus erythematosus. Generalized urticarial plaques with tense blisters and oral may occur. Also the same, subepidermal bully with neutrophils, the direct immunofluorescence, immunoglobulin G and complement 3. Now we will start on the immunoglobulin A bullous dermatosis, the DH, dermatitis herpetiformis, the linear immunoglobulin A dermatosis, LAD or LAD, and chronic bullous disease of childhood. Introduction, epidemiology. Now I will make it all comparison. Epidemiology, DH, all ages, increase HALA B8, DR3, increase gluten-sensitive enteropathy and lymphoma. It's very chronic, lifelong, with good general health. The epidemiology of linear immunoglobulin A dermatosis, occurs in all ages. Also, there is increased HLA B8 and DR3, but no increase in gluten-sensitive enteropathy, like there is in lymphoma. It lasts for 3 to 5 years and few persists. The chronic bullous disease, it is only not in all ages, only in 3 or 5 years before the age of 5, and there is increased HLA B8 and DR3 also, no gluten-sensitive enteropathy and no lymphoma, and also lasts for 3 to 5 years and few persists. Usually spontaneous resolution before puberty. This is the epidemiology. We will give information about generally. It is the linear immunoglobulin A dermatosis and chronic bullous disease of childhood. They might be the same disease but in different age groups. And also the linear immunoglobulin A dermatosis, it's some sort, we will talk about the same clinical picture and histopathology of DH, but we can differentiate them by direct and indirect immunofluorescence, where the direct immunofluorescence is linear in the immunoglobulin A dermatosis and globular in DH, and indirect is it is negative in the DH, and there is anti-basement membrane zone against basement membrane zone immunoglobulin A depositions. And the antigen here is, we will talk about too much like bullous pemphigoid antigen and other antigens, and for the DH it is unknown. Now we will talk about the clinical picture. Clinical picture of DH. It occurs at the elbows, knees, and sacral, and extensor of the limbs and shoulders, the upper back, buttocks, and trunk. There is a group of erythematous, papules, vesicles, and urticarial with grouping, crustaceans. Sometimes there is no bully, usually it is misdiagnosed, but when there is H, think of DH, and so there is intense pruritus that heal with pigmentation and scarring. Oral lesions are absent. The chronic bullous disease of the linear immunoglobulin A dermatosis It is a chronic autoimmune bullous disease that occurs in childhood and in adults. Clinical picture and histopathology, as we said, it is the same as DH. Bullous pemphigoid-like lesion may occur also. Usually there is annular erythema and articarial plates with vesicles around the periphery is characteristics, and there is oral lesions in the majority. For the chronic bullous disease of childhood, clinically it occurs in the extremities, especially thighs, buttocks, trunk, and also in the genitalia and perioral. There is tense bulli and vesicles on erythematous and or normal skin. It occurs sometimes. It heals with hyperpigmentation, of course, and usually the bulli is arranged in annular pattern, which is called clusters of jewels or string of pearls. It heals with hyperpigmentation. Also, there is oral lesions in the majority of cases, sometimes 50% of cases. We should differentiate it from juvenile bullous pemphigoid. Of course, in juvenile bullous pemphigoid, there is immunoglobulin G positive. Here, there is immunoglobulin A positive. There is associations with the DH, which is gluten-sensitive enteropathy, celiac disease, 90%. There is partial or total villus atrophy of small intestine, usually asymptomatic. Prolonged treatment with gluten-free diet improves both GIT symptoms and, to a lesser extent, the skin lesions. There is immunoglobulin G and gluten that goes to the circulation, which has similarity between antigen, mucosa of the gut, and skin basement membrane zone. So there is also another association, defective mucosal barrier, almost in all patients, and also there is sometimes diabetes mellitus, thyroid disorders, and internal malignancy as lymphoma. This is the associations with the DH. Gluten-sensitive enteropathy, defective mucosal barrier, and some chronic diseases like diabetes, thyroid, and malignancy as lymphoma. This is the clinical picture of the immunoglobulin A bullous dermatosis. The histopathology, both are subepidermal bulla with neutrophils, mainly subepidermal bulla with neutrophils. But for the DH, early in the disease, there is microabscess at the tip of dermal papilla. There is neutrophils at the tip of dermal papilla. Then it becomes subepidermal bulla with neutrophils, especially best seen in perilesional skin. There is a note here, microabscesses in dermatology. There is the DH at the tip of dermal papillae, neutrophils at the tip of dermal papillae. There is the Potrier microabscess in mycosis fungoides, cutaneous T-cell lymphoma. There is atypical lymphocytes surrounded by halo in the epidermis. And there is the Monroe microabscess in psoriasis, where there is polymorph nucleus in nuclear leukocytes in the stratum corneum. This is the type of microabscess in dermatology. Now there is, this is the histopathology of DH, subepidermal bulla with neutrophils, and early there is microabscesses in the tip of dermal papillae. And for linear immunoglobulin A dermatosis, it's the same subepidermal bulla with neutrophils. For chronic bullous disease, it's the same subepidermal bulla with neutrophils, but sometimes there is eosinophils or admixture of both. Immunohistopathology, direct immunofluorescence from perilesional skin. There is in DH immunoglobulin A granular deposits at dermal papillae, A1 of gut origin. In the indirect immunofluorescence, it is negative. So the direct immunofluorescence, there is granular deposits of immunoglobulin A, autoantibodies, and for the chronic bullous, for the linear immunoglobulin A dermatosis, there is immunoglobulin A which is homogeneous and linear deposition at dermo-epidermal junction at the level of lamina lucida and sublamina densa. For indirect immunofluorescence, there is low titr 30% in adults, and in children it is 80%. And for the chronic bullous disease of childhood, there is also the direct immunofluorescence, immunoglobulin A positive, linear deposition at dermo-epidermal junction at the level of lamina lucida and sublamina densa, and indirect immunofluorescence, there is Also anti-basement membrane zone immunoglobulin A antibodies, of course with high titer here. For the indirect immunofluorescence of DH, it is negative, but there is other antibodies, anti-reticulin antibodies, anti-gliadin antibodies, anti-thyroid antibodies, anti-immunoglobulin A complex, immune complex, and anti-endomycelial antibodies. But these are negative in the other two diseases, no anti-reticulin and no endomycelial antibodies. And there is a note that it is likely that lead and of adult and chronic bullous disease of childhood are the same disease. This is the histopathology and immunohistopathology. For the pathogenesis, the antigen in DH is unknown now, but the antigens in the linear immunoglobulin A dermatosis and in chronic bullous disease of childhood are many antigens, which are, example, bullous pemphigoid antigen 180 and 230, and also collagen 3 in anchoring fibrils. In the DH, there is defective mucosal barrier that allows passage of macromolecules as gluten to lamina propria with formation of immune response, immunoglobulin A antibodies. Immune complex enters circulation, immunoglobulin A complex deposited in dermal papillae with release of chemotaxis and blocked by, which this step is blocked by dapsone and accentuated by iodides. So after that, release of neutrophils, which leads to secretion of proteolytic enzymes and separation at lamina lucida and bulla formation. The treatment is dapsone, of course. This is a therapeutic test in DH. We give 100 to 200 milligram per day. It is a therapeutic test. It is response with 48 hours. If it is not effective, we will change the diagnosis. So of course, we will make gluten 6 CPD should be done, and glucose 6-phosphate dehydrogenase, and also alternate treatment is sulfapyridine, 12 gram per day. Gluten-free diet here will ameliorate skin lesions in some patients and allows to give less dapsone or stop it and protect patient from lymphoma. Of course, there's a note that non-steroidal anti-inflammatory exacerbate DH even if he's taking dapsone. So there is dapsone, there is alternative sulfapyridine, and gluten-free diet. Also, for the other two diseases, the same treatment. Dapsone is effective, and sometimes combination of dapsone and prednisolone, and alternate treatment of sulfapyridine, sometimes interferon alpha steroid in severe cases. Also, there is, for the children, there is dapsone with a dose of 20 to 125 milligram per day, and sometimes in combination with prednisolone, and alternate treatment is sulfapyridine here, 250 milligram to 3 milligrams per day. This is the treatment of the DH and the other two diseases. Now we will look to the clinical picture of DH. We see here group papules, vesicles, and crusts of the back, and here also there is papules, vesicles, and crusts on the knees. And here we can see the DH firm top vesicles and bully with erosions and residual hyperpigmentation. Some are arranged in the annular pattern, and also here there is the pattern of distribution of DH. Here we see the direct immunofluorescence showing dermal papillae, granular dermal papillae, papillary deposits of immunoglobulin A. Here there is the biopsy of the DH, collections of neutrophils in subepidermal vesicles in high and low magnification. Now we will see the lead and chronic bullous disease of childhood clinical picture. linear immunoglobulin A dermatosis, crusted erosions, papules and vesicles in the back and neck. And here also there is grouped, to the right, grouped urticarial papules, scattered crusted lesions. And we can see here also to the left annular erythematous plaques on the thighs. And on the right, this is the chronic bullous disease of childhood. The tense bully crusted papules are present in the abdomen with clustering of bulli noted in perineal region. And here we see the two presentation of chronic bullous disease of childhood. There is bully on erythematous base on the upper picture, and there is bully on normal skin on the lower picture. Here there is subepidermal bully with neutrophils in the immunoglobulin A dermatosis, linear immunoglobulin A dermatosis. This is pictures also of a clinical picture of DH, chronic bullous disease of childhood. As we can see, the string of pearls and clusters of jewels.